This chapter will cover 3 classes of sexual and gender disorders. We will begin the chapter, however, by talking about general principles of the human sexual response before we go through the disorders that include sexual dysfunction, paraphilic disorders, and gender dysphoria. It's important to realize that in all of the classes of disorders covered in this chapter, it is not considered a disorder unless it is recurrent, persistent, and distressing, or involves non-consenting partners. Almost everything that we know about human sexual functioning is due to the pioneering work of Masters and Johnson and the scientists who followed after Masters and Johnson. Masters, a physician, Johnson, a psychologist, at one point married, but even before they married, had a great partnership in studying the human sexual response from both a psychological and a physiological perspective. They literally study people engaging in sexual behavior while measuring their physiology and looking at the differences in personality and how those affected sexual responses. Their pioneering work showed us that there are stages of sexual responses, and the work on sexual dysfunction recognizes that each of those stages can represent problems in sexual behavior. The 4 stages of sexual dysfunction include desire, excitement, orgasmic, and resolution phases. Note that your textbook does not measure or does not mention the desire phase, but virtually all textbooks do, and certainly the work of Masters and Johnson emphasize it. The excitement phase also in your textbook is referred to as the plateau stage, a term that is used in some other textbooks as well. During the resolution phase, we typically return to a baseline state, but sometimes we re-engage in sexual behavior if we are capable of doing it. There's always a period, however, where we're not capable of doing it, and that's called a refractory period. Although there are slight differences between males and females, and some of those slight differences actually have huge implications for sexual behavior, the differences are by and large relatively small. These graphs show the human sexual response for males and females, and at first glance what you should notice is by and large a very similar shape. What we're graphing here is the level of physiological arousal across time. 4 stages: desire, during which there's no physical contact yet, but there's an interest in physical contact. Excitement, that involves physical contact up to, but not including, orgasm. The orgasm phase, which represents a very rapid increase in physiological arousal, followed by an equally rapid decrease. And then a resolution phase, where the individual returns to the baseline state. Now, comparing the males and females, you can see some interesting differences. In males, for example, the desire phase can bring males to a very high level, almost sufficient to trigger an orgasm without any physical contact at all. The excitement stage, which your textbook refers to as plateau, is sort of a plateau for males. There's a gradual increase, but not dramatically so. But notice in females, the excitement phase can lead to much higher physiological arousal. What is the implication of that? Women typically need more foreplay to be able to be ready for orgasm. The orgasmic phase for males and females is very similar, except males, once they have an orgasm, have a refractory period that increases with each orgasm. Females are capable, they don't necessarily have it, but they are capable of having multiple orgasms in a very short period of time. And then notice the difference in the resolution phase. In males, the resolution phase is very rapid, and in females, it's much slower. Guys, what that means is that after you make love to your partner, she will want to cuddle, and you will want to fall asleep. If you resist the urge to fall asleep and you spend a little time cuddling, you will definitely improve the relationship with your partner. By the way, if a woman does not have orgasm, she can still have a pleasurable sexual experience. Not as pleasurable as if she has orgasm, but it's still pleasurable and it's still reinforcing. But the resolution phase will be much slower for her, as illustrated by the dotted line that you see in the female sexual response. Assessing sexual functioning is a complex task. Following Masters and Johnson approaches, typically an interview is used to get a detailed sexual history and specifics about what is going on now, both in terms of the positive and the negative aspects of sexual functioning. But a medical exam is equally important because there are a variety of medical problems, such as diabetes, that can definitely interfere with sexual response. And almost all painful sexual intercourse is the result of a medical problem of one sort or another. It's also possible for us to now study sexual excitement and do it in a way that is not nearly as invasive as what Masters and Johnson originally did. For example, a penile plethysmograph is a strain gauge that can easily be put around the penis by the male and done without the help of anyone else. The wires from the strain gauge simply come out of the top of the pants and can be plugged into an amplifier. And as the male becomes excited, you can get second-by-second measurement of how excited they are. For women, it's called a vaginal photoplethysmograph. Unlike measuring the change in size, which is very difficult to do with the vagina, what the vaginal photoplethysmograph does is measure the change in lubrication by passing a small laser light that will bounce off of the walls of the vagina, but will bounce off more light once the vagina starts to lubricate. Masters and Johnson, through their research, challenged a number of the sexual myths that have been around for a long time. Actually, they challenged dozens of them, but let me just focus on some of them. It used to be, based on Freudian psychodynamic theory, that a woman who had to have direct clitoral stimulus rather than just vaginal penetration to achieve an orgasm somehow did not have an adequate sexual response. The truth is, all sexual response and orgasm in women is due to clitoral stimulation. For some women, that is achieved very easy through vaginal penetration because of small differences in how their vaginas are put together. But for other women, it's harder. By the way, males and females both have the equivalent of a clitoral stimulation. For the males, it's on the underside near the tip of the penis. And of course, for males, that means that when they are penetrating the vagina, they will always have direct clitoral stimulation, or at least stimulation of that part of the penis that's responsible for triggering the orgasm. So vaginal orgasms are not better, as Freud and many others had claimed. Many people thought the ultimate was to have simultaneous orgasms, but in fact that's not the ultimate. If you're having an orgasm, it's very hard to appreciate the pleasure that comes from watching your partner have an orgasm. So having separate orgasms is actually better. And the idea that size matters is really not true at all. It's more a matter of technique than size in determining the pleasurable sensations from sexual intercourse. Sexual dysfunction refers to an inability to perform behaviors that most people would consider not only normal, but desirable, such as sexual intercourse with your partner. The disorders fall into 4 categories. 3 of them represent the first 3 stages of sexual functioning: disorders of desire, excitement, and orgasm. And the third is a separate category of sexual pain disorders. Let's start with disorders of desire. Now remember, with desire, we are not talking about any sexual contact yet. We're just talking about interest in having sexual behavior. Hypoactive sexual desire disorder. Hypo always means less than. So less than normal sexual desire disorder is having little or no interest in sex. It affects about a third of women and about a sixth of men. And we don't include anyone in this category who has decided for philosophical or religious reasons to not be involved in sexual behavior. Also in this category is sexual aversion disorder. That's more than just not having interest. That's finding the thought of having sex aversive to the point that one has no desire, and in fact the idea of having sex is disgusting. This is relatively rare. It's much more common in women, and it's often associated with having been sexually assaulted and violated. Although there are a few people with sexual desire disorders, the truth is, for many of the sexual desire problems, they're intermittent and they're a function of what's going on. Quite frankly, it's hard to be interested in sex when you're in the middle of severe distress of a psychological nature. Hormonal shifts can have some effects, although not as much as we once thought. Relationship problems often make it very hard to want to make love to your partner. The fact that we call sexual intercourse making love is not an accident. If you are angry and hate your partner for various things, making love is frankly very difficult. Again, as I mentioned, sexual aversion disorders is relatively rare, and it almost always is associated with sexual trauma. Prior to the trauma, typically there was no sexual aversion disorder for the individual. Moving to the next stage, we're talking about disorders of excitement. Now remember, at excitement, we are talking about a response to physical contact. Let's use the generally used phrase of foreplay to refer to this stage. We divide the disorders of excitement into female sexual arousal disorders and male erectile disorders. In a sense, they both represent the same thing. Female sexual arousal disorders means that the woman is not experiencing the physiological changes during foreplay that prepares her for sexual intercourse and for orgasm. That involves a swelling of the vagina and a lubrication which makes penetration more comfortable and pleasurable. By the way, the swelling of the vagina is very similar to the swelling of the penis that leads to an erection. It's the same physiological mechanisms involved in both cases, basically a change in blood flow. Male erectile disorder is perhaps more obvious and easy to see because the penis is external compared to the vagina, which is internal, and so you can see whether you have an erectile problem or not. The process, again, is the same, change in blood flow. Erectile disorder is actually relatively common, and one reason why an enormous amount of money is made by drug companies who sell drugs to help with male erectile disorder. The graph that you see here shows that age has a huge effect on erectile disorder. In one's 40s, it's very rare to have males, only about 2%, who have total erectile disorder, but up to a third of males in their 40s will have at least intermittent erectile disorder. But by the time you reach your 70s, almost 2/3 of males will have at least intermittent, and about 12% have complete erectile dysfunction at that point. What contributes to disorders of excitement? Frankly, excitement is a physiological change, and you have to be physiologically healthy to be able to experience that. There are a variety of problems that can lead to excitement problems associated with sexual response. These include things like diabetes, but also circulatory problems or hypertension. Remember, disorders of excitement involve changes in blood flow in the genitalia. And so if you have anything that affects blood flow generally, such as hypertension, you are definitely going to have a high likelihood of problems. Hormones can play a role, but usually they're not the primary role. Alcohol and drug abuse will inhibit the functioning of your physiological systems that are involved in sexual behavior. That's interesting because anxiety is often an issue with sexual dysfunction, and so many people who are anxious about sexual response may use alcohol as a way of reducing the anxiety, but if they drink too much, they may reduce the physiological responsiveness needed to engage in sex. And stress. Remember, stress makes everything worse. Social support makes everything better. It is very hard to enjoy and perform sexually if you are seriously stressed out. We recognize 3 disorders of orgasm. The most common is premature ejaculation in males, which is defined by Masters and Johnson not in terms of the amount of time between penetration and ejaculation, but in terms of the partner's response. In fact, in all of the work of Masters and Johnson, they recognize that everything involves the effective coordination of 2 people responding together. So, premature ejaculation is defined as ejaculating too quickly after penetration and therefore not allowing one's partner to reach orgasm as well. Premature ejaculation is very common in young men, and we'll talk about why in just a minute. It's rare in older males. Male orgasmic disorder is much less common, and usually it involves an inability to reach orgasm or requiring far too much time to reach orgasm, to the point where it becomes physically uncomfortable to continue the sexual intercourse. In females, it's also defined the same way, an inability to reach orgasm in a reasonable period of time. It's relatively common in women, much less common in men, although it is becoming more common in men over time for reasons we don't fully understand. So what contributes to these disorders? As I mentioned, premature ejaculation is very rare in older men, but very common in young men. And the vast majority of young men will simply grow out of it in a matter of a year or two. Young men tend to be highly responsive sexually. It's often been said that young men reach their sexual prime at 18, and in contrast, women tend to reach their sexual prime around 30 or 32. What does that mean, reach your sexual prime? It's defined by how quickly you reach a sexual climax. For most young men, that's a problem. They will develop an erection, which, depending on the pants they're wearing, could be very embarrassing, with almost no stimulation whatsoever other than just desire. Women do not respond that quickly, not even close. But as women get older, they tend to become more sexual. They tend to be able to enjoy sex more. They tend to be able to become more excited and more powerful orgasms. And if they're multi-orgasmic, become more likely to experience multiple orgasms with experience. Males are just the opposite. For orgasmic disorders, in women particularly, it appears to be very important that they learn how to have orgasms. For example, it's very uncommon for women who masturbate regularly to have an orgasmic disorder, but women who have no experience with orgasms through masturbation often have difficulty learning to let go and have an orgasm. It is a physiological response, and although much of that physiological response is natural and doesn't have to be learned, the fine-tuning of that response is often a matter of some learning. Many people find, for example, that their early sexual responses, early sexual behavior is very pleasurable, but not nearly as pleasurable as it is after they become more comfortable with their partner, learn what their partner likes, and their partner learns what they like. Any kind of nervous problem or neuronal problem can result in an inability to experience orgasm. Now, typically that's a part of a general nervous system disease that affects a lot of things, so the disruption in orgasm is often a relatively minor symptom in a much more serious constellation of symptoms. But it's very common to see this as one of the first symptoms of a nervous system disease. There are two sexual pain disorders that we're going to cover in this chapter. One is called vaginismus, and by the name you can guess that it affects women. Essentially, what we are talking about is an involuntary tightening of the muscles of the vagina. Think of it as a Charlie horse of the vagina. Now, if you've ever experienced Charlie horses in your arms or your legs, you know that they are incredibly painful. But imagine having a Charlie horse in the part of your body that has more nerve endings than any other part of your body. And you can understand how incredibly painful that will be. Now, what triggers vaginismus in most cases is penetration. So the vaginismus responses are occurring while a couple is making love. So not only is the vagina incredibly painful because of the spasms that the woman is experiencing, but the male is experiencing incredible pain because his penis is being crushed by those spasms. Not surprisingly, although vaginismus is relatively uncommon, almost all people who experiences it, all couples, will seek treatment because it's a terrifying and very painful disorder. Genital pelvic pain penetration disorder. That's a mouthful. Basically, in English, it means when I'm making love, it hurts. My penis hurts, my vagina hurts. It's more common in women because the cause of this in most cases is scar tissue. And women experience a lot of trauma to their vagina through childbirth. Males, of course, don't give birth like that, so they are less likely to have it. But in most cases, as you will see shortly, it is some sort of scar tissue on either the penis or the vagina that's being irritated by the penetration of making love. The evidence now is overwhelming that sexual pain disorders invariably is the result of some sort of physiological problem. And sometimes the diagnosis of that physiological problem requires microscopic evaluations of the penis or the vagina of the individual experiencing pain. What I want to emphasize here is that at one time we believed that sexual pain disorders were a psychological phenomenon, that it was a psychological aversion to having sex that was translated, converted, you can see this psychodynamic principle, into a physical discomfort instead of a psychological discomfort. We don't take that seriously because there was never any evidence for it, and the evidence for physiological problems is overwhelming.